Hi everyone, good afternoon. Thanks everyone for joining, and we'll talk about mitral valve stenosis today in echo teaching. I guess out of all the valvular diseases, this is probably one that's probably not the most common. I think it's only about maybe 10% of all native valve diseases are mitral stenosis, but it's the one that's talked about a lot in the exams. And particularly for the ASE exams and in the DDU, this has certainly come up multiple times because I guess there's a lot to talk about in terms of the optimization for the echo images and how to analyze it. So we'll try and go through it in a systematic manner. I've got a couple of cases at the end. If you've got any questions, please chime in and interrupt whenever you like. Going to try and bring in a few multiple choice questions to understand that some of you are maybe not doing the DDU exam and might be thinking about doing the American Echo Board exam. So I'm going to start bringing in a few of these and maybe we'll talk through how to answer some of these questions. So these are stolen out of an American Echo Board exam book that I've got here. So I'll start with this. The most common etiology of mitral stenosis in industrialized countries is which? Is it rheumatic fever, degenerative changes, connective tissue disorder, congenital, or left atrial tumors? Who wants to have a crack at this?
It's rheumatic, 99.
Nice, absolutely. So it's rheumatic by I guess the other question that you might come up with would be, it could potentially be degenerative. In industrialized countries, obviously those are going to be the most common causes. But rheumatic fever, you're absolutely right, Vishal, that's the one that is most common cause for it. And we find about 2/3 of patients with rheumatic fever have mitral stenosis. In terms of connective tissue disorders, Ehlers-Danlos syndrome, Marfan's, and some of those connective tissue disorders, they can cause maybe more of a prolapse rather than stenosis. So certainly you can see mitral regurg with those, but maybe not so much mitral stenosis. Congenital ones, sort of struggling to think of them. Maybe some of those parachute mitral valves can potentially, the parachute one that comes out there can potentially cause some stenosis. Other congenital ones, maybe you get those double outlet. I don't know if that's a proper stenosis, but you get double outlet mitral valves. Taking valves individually, they could certainly be stenotic. I'm struggling to think of any other congenital ones. Left atrial tumors, myxomas, they can certainly cause stenosis. And if I get a case, I'll immediately show it to you because it's super rare, obviously. So yeah, that's great. Absolutely. Rheumatic fever is the most common cause. And as I said, about 2/3 of patients with rheumatic fever have some form of mitral stenosis. If you take mitral stenosis by itself, about 10% out of all sort of big heart valve disease, and I've only got data there on Europe, so that's why I've stuck that in. And if you're going to have mitral stenosis, 50% of them are just mitral stenosis, and 1/3 of them you often get the aortic valve stenosis going on with it. It's more common in women than men, and the rheumatic fever and the degenerative changes in the industrialized world make up 99% of those. So they're certainly the most common cause for those. I'll just talk a little bit show a couple of pictures about rheumatic heart disease and about the degenerative changes now. Okay, so first of all, the rheumatic heart disease, the most common cause of mitral stenosis, both in developing countries and here. You get particularly leaflet tip thickening and fibrosis and calcium deposition. You can also get the thickening of the cord itself that's coming off. And together with the leaflet tip fusions, you start getting that commissure, the commissural parts between the leaflet, between the smiley face, the commissural parts get thickened. And that's what leads to the valvular stenosis. But you can also get a lot of these ones also get valvular insufficiency with that. So you can get pretty bad regurgitation going along with this. So if you are seeing mitral valve stenosis, you've got to go checking for the mitral valve regurg. And that, of course, is going to be relevant when we start talking about how to quantify this. Now, I've forgotten how to say this next bit, but it's something like Aschoff bodies, and then it's Chicago cells. I can't remember. There's some special way you're meant to say that. And they get deposited in the myocardium. So the myocardium is not normal either. All right? And you can see the sort of little nodules, vegetations appear on the valves as well. So just in summary, it's leaflet tips and the cords that are thickened. The commissures get thickened. That's what makes it stenotic. And you can get stenosis as well as regurgitation. And the myocardium is often not normal as well. degenerative ones we see all the time, and particularly the mitral calcification. It's pretty rare for it to cause rip-roaring, horrific, severe stenosis, but certainly you can get mild ones that are seen all the time. And often I find that if you're seeing significant mitral calcification, you're going to see it in other places as well. And you're getting a lot of this sort of fibrosis and calcification in particularly the aortic valve as well. And you're seeing atherosclerotic lesions in addition. All right, so those are the two most common ones that we're going to see, and those pretty pictures. Valve area, so normal, bigger than 4, severe, less than 1. Severe, you're just going to start to see symptoms when you start to get less than about 2 centimeters. Here I've got some images of planimetry, and we'll go on to talk about this in a second. These 2D imageries for the planimetry, as I'm sure you're going to know, are going to be fraught with dangers, and maybe we'll get someone to start talking about why these are not accurate ways of measuring it, particularly in transthoracic echocardiography, and we'll talk about that in just a moment. But normal, greater than 4 centimeters squared, severe, less than 1 centimeter, and we start to sort of get that mild to moderate category, and we're starting getting out to the 2 centimeters. So I have 1 and 2 in my head as being the important ones. In terms of the pathophysiology, obviously, if you're getting a blocked up valve that's stenotic with the commissural fusions, you get raised left atrial pressure. That means that you're going to impair the filling of the left ventricle, and that impairs the cardiac output. You often don't see LV abnormalities with it. It's just an underfilled LV that doesn't have enough blood coming into it. So it's not like you get a big blown out LV or LV dysfunction. It's just underfilled ventricle, which is classically the way that it prevents. And then all the problems that comes from left atrial pressure elevation. So you increase risk of atrial fibrillation, which is very poorly tolerated. You get increased risk of thrombus formation. You get increased left atrial size. You get the pulmonary hypertension, congestion in the pulmonary system, RV dilation, tricuspid regurg, and RV failure. And so it's all from left atrial hypertension. Okay. So what can you do about it? Well, I'll see if this one works. This is a great picture. So I guess in the standard outpatient setting, and this is not in the intensive care critically ill population, but I'll mention it briefly again, because if you're doing the ASE exams, they love asking about this. So we're obviously looking at percutaneous mitral balloon valvuloplasties. Here's a beautiful picture. We'll see if it comes up nicely in this. So thanks, Atish, whoever you are, for doing this. I thought this was really cool. So it's got the echo picture below, and then you've got the valvuloplasty on the top. So you can just see that last little bit as they dilate it. It breaks that commissures to open up the valve, and you can sort of get an idea of what it looks like underneath. And it's just that middle bit that you can see just at the end. It goes and bursts it open. So it's just splitting open those commissures. So I think that's pretty cool. Nice little image there. And I can't remember how to get back to my talk now. So they'll talk about the Wilkins score, and I think they also talk about the, I forgot what it's called, the Coumer score or something. The Wilkins one is the one I think that's used more often. I guess I don't use this a lot, so again, I'm just getting this out of textbooks. It's not something that I'm doing routinely, is giving the Wilkins score, but they will ask you about it. The bottom line is that they have for this is you've got a grade 1, 2, 3, 4. You've got 4 things that you're going to be able to score on. If you get a score greater than 8, that means that you are not going to be great to have this procedure done. Okay, so if score greater than 8 is bad, less than 8, you can be considered for it. And so it's based on mobility. And obviously, if you've got completely fixed, immobile leaflets, if you crack them open, you're probably not going to get nice flow coming through it again. In terms of thickened leaflets, if they're super thickened, again, if you crack the commissures, they're probably not going to work beautifully after that. Lots of calcification there. If you break it, that can cause problems with the valve. And if you've got extensive subvalvular thickening, again, cracking the valve at the commissures might not change the way it works. So the higher the score, the least likely it's going to be that the balloon valvuloplasty percutaneously is going to help. So lower scores you can, higher scores you need a valve replacement. All right. But again, they'd expect you to know some of these scoring systems for the ASE exams. Right, let's get to the good stuff. So assessment, particularly if you're finding patients who've got, why is this relevant for the critically ill is because if you see patients who've got mild disease who are hemodynamically hyperdynamic, or they are moderate disease and they are, you know, and they're hypovolemic, you know, you might underestimate or overestimate severity. So in the critically ill, if you think someone's got mitral valve stenosis, and I'm going to show you a great example of this in a moment, you've got to know how to assess it. And it's not straightforward, and it's not just 2D, and it's not just color Doppler. Okay, so Doppler analysis with pulsed wave and continuous wave Doppler is essential, and not just looking at the left side again, you've got to look at the right side as well. So this is why it's in all the, you know, it's why it's so commonly asked in the exams, is because it's, you know, you've got to have a good understanding of how to do echo. And from the DDU side of things, I think if you can answer a question well on, you know, aortic valve stenosis or mitral valve stenosis, you probably get echo. So we'll talk about the assessment of it. You know, first of all, it can help diagnose the lesion. Then we can assess the valvular anatomy, particularly with the 2D. We can then look at the evaluation of the severity, possible consequences, and other lesions, particularly with the Doppler analysis. I've put a line through M mode because in all the recent papers and all the recent guidelines, they're talking about it not actually being that great and not that useful anymore. I'm going to leave it in there. I'm going to show a few things because I think it's a bit geeky and kind of cool. I like M mode, but also the ASE exams, they love asking about M mode. So again, I think they go under the premise that if you know M mode, you know echo. So it's worth, I'll show you a couple of pictures and we'll talk about through it. Okay, so really quickly, 2D findings. We'll go through this pretty quick because I'm sure you guys all know about this. So here we can see the leaflets are thickened at the tips of it. We have particularly greater than 3 millimeters, and it's particularly the chordae and the tips. You have these shortened, thickened chordae, and then the tips of the leaflets give you that hockey stick appearance. And the hockey stick is an American ice hockey stick. It's nothing like the field hockey or the field hockey that we know. It's all about ice hockey sticks, and that's the one that looks like the sort of the L shape. And so if you see that leaflet tip being thickened and at a sort of 90-degree angle during sort of the peak diastolic filling, that's what they mean by that, particularly anterior mitral valve leaflet during systole. You have a big old left atrial, so you can see sec that goes in there, and you can have a dilated, badly functioning right ventricle. So if you see this and you're talking, you know, if you see the hockey stick appearance, don't just stop at that. Go and talk about the left atrium, talk about sec, talk about the chordae, not just the leaflet tip, and talk about the right ventricle. You know, those are the kind of patterns that you'd be expected to bring out in the exam. And we'll you know, we'll go through that in just a second in the cases. And here you go. I've got a still picture there. You see a sort of 90-degree angle for that sort of L shape coming through for that anterior mitral valve during diastole. Okay, so here's the M mode. Where do we get? Who's gone? Ramsey, tell me what. So this is the M mode of that patient with mitral stenosis. What do you see that's weird?
So I really don't do M mode very often, so I'm struggling here a little bit.
And you can be forgiven because you're doing the DDU, not the American Echo Board exams, aren't you?
I'm actually planning to do that as well. So.
In that case, you're in trouble. I'll tell you what, I'll make it a bit easier. I'll put the normal on top of it there. So we've got...
So you usually will see 2 openings,
cool.
which of course you don't see here.
And so it's particularly one of the things we talk about is the EF slope. Okay. Right. So first of all, if we've got this sort of fusion of the E and the A waves, it's also this EF slope, which here you see is just a sort of that thickened cutoff. So the findings that we might be able to talk about here, I'll pull up on the left. So first of all, it's the reduced EF slope. So instead of having that nice sharp angle, as like we'd see in an ordinary, I sort of think about it, look like the E and A wave on Doppler, right? Instead of that sharp deceleration, that's all out on a line. The next thing that we can talk about, it doesn't come up very well in here, is you can get a bit of anterior motion of the posterior leaflet that sometimes you see in here, sort of bowing in. And again, that's a thickened, immobile leaflet that's got the caudal thickening, and so it doesn't move very much. We don't have an A wave, so you've got loss of the A wave because the leaflets are so thickened and sort of held out and don't move nicely. You can see atrial fibrillation. Don't forget to look at the rhythm underneath. And what else can we say about this? And I think the thickened leaflet tips, the thickened anterior mitral valve leaflets. You see, normally it's a nice thin structure that moves up and down, and here you just got that thickened, reduced EF slope there. So a few things to pick up on M mode. Again, they love talking about it in the ASEs, so just make sure worth going through a little bit of M mode.
Then if you draw a timeline on that M mode, is the anterior light and is the AML motion lagging behind the PML opening?
Just so sorry, I missed some of that. Can you say that one more time? Is the anterior mitral valve lagging behind the
PML?
Yeah, nice. So I think maybe I don't know, I can zoom in. Maybe this one here, you can start seeing the PML coming in there as well. And I think it lags behind it because it's so thickened and immobile, and it sort of gets pulled in because of the reduced filling. And one of the other findings that, not to spoil the story, is I think it also comes in here in early systole. You see there's this little bounce that comes in here. And I'll show you a case of this in a second. It's the same thing. It's like with impaired filling of the left ventricle, you can get a little bounce in systole because the LV isn't filled very well, which is one of the reasons why I think the posterior mitral valve leaflet gets pulled in. But it also means that during systole, the right ventricle, which contracts a little bit before the left ventricle, if the left ventricle is horribly underfilled, you get a little early septal bounce. So I think that's why it lags behind it, is because of impaired filling. I think that's right.
Sam, can I mention one thing about EF slope?
Yeah, totally.
So,
Michelle loves M mode. Here we go.
So no, like just the one point to make, that normal EF slope is more than 60. If it's less than 30, then you think about mitral stenosis.
And do you mean, so this is the decel time coming down through here? So if you actually to measure that, normal is
more
greater
than 60,
greater than 60 and less
than 30, then you think about mitral stenosis.
Thank you very much. Excellent comment. Okay, 2D findings. Right, this is all the time. Danielle, tell me about this. So we got 2D. I've made a measurement here on that patient. Let's say I measured it at 1.5. Can I just stop there? I mean, this is planimetry. This is the fish mouth orifice. I can see my thickened chordae, the thickened commissures. Why don't I just stop at that? What's wrong with this measurement?
So limitations of the parasternal short axis fish mouth perimetry particularly on transthoracic, I guess, would be the potential for poor image quality, making it a difficult measurement.
I guess with transthoracic, right? So toe, it can be even a little bit better. I don't mind it so much on toe, but I do mind on transthoracic because of image quality. And you can see it's a bit rubbish here, right? Yeah.
Obviously, the timing of when you take the measurement is going to be important.
Nice. That's why I've cut that off. Yeah.
And the angle at which the image is taken, so it would need to be exactly at the commissural tips, I suppose, and exactly during what mid-diastole, I suppose, to get the maximal planimetric measurement. Yeah. Is that right?
Yeah, I have it when it's open up to its biggest point, and that's absolutely, I guess normally that's with the and normally that's going to be, it's difficult to say, I guess. If you've got raised left atrial hypertension, I think early filling is probably when it would be the biggest, so about mid-diastole, but it's to try and find out when it's at its biggest point that you measure it out.
So that would be one of the caveats, that it would need to have been taken at the correct time.
Yep.
And then I don't know, I mean, you might get, depending on where your gain settings are, and if the valve is extremely calcified, then some of the machine settings may actually have an impact on the measurement that you get. Yeah. And lastly, what else can I say? I don't know. So I don't know whether there's an important difference between the kind of effective and the actual valve orifice area with regards to mitral stenosis. I mean, the cutoffs are the cutoffs, and that's based on planimetry. I don't know if that would count.
Yeah, and I think that's probably more important when you talk about the vena contractor. That's going to be different where it's at the actual orifice size versus where the sort of smallest point is. I think it's more important for the vena contractor, not so much with this. We're talking about the smallest orifice area size that we're trying to measure. Yeah. Can you bag out the picture that I've taken here? Can you tell me some good things I've done and tell me some bad things I've done on this picture?
So look, I think if I was going to take this measurement, you'd want to alter your depth settings and your segment settings so that you've got the best possible, the best possible image. And you would want to zoom in probably on the mitral valve orifice as well in order to maximise it.
Would it be reasonable to say that that would be both temporal, that would improve your temporal resolution as well as your sort of axial resolution? So if you're zooming in, just focusing on one area, you could have better temporal and axial resolution. Nice.
It looks like maybe on this image you've got a little bit of lung shadow coming down the edge as well, which hasn't actually impacted on where you've taken the measurement itself. But it just suggests that maybe there's some difficulties with image acquisition in this particular patient that might be improved by repositioning either the patient or the probe.
I was going to say, I think maybe the only thing I've done well, I haven't optimized my gain, I haven't zoomed in on the image. I've put the focus position in the right spot. How about that?
Yeah.
You can say that's the one thing I've done.
You've done that, yeah.
Thank you. All right. Fantastic. So let's talk about so color Doppler and Vena Contractor would be the next things. I think I often find the color Doppler is the thing that sort of triggers me if I'm worried about mitral stenosis. The color Doppler helps, and there's this beautiful, they call it a flame jet. It looks like a sort of the top of a candle, and I think it looks, it's pretty beautiful there. And also you can get that turbulent flow coming in, so you get a lot of variance that comes. I don't think I've got the variance on this one, but you can see it in the bottom one, measuring the Vena Contractor, which is at the narrowest point of the stenotic jet that comes through. And I think the magic number, I'm going to forget off the top of my head, I think it's 7, just like it is. I think it's 7 millimeters, and I'm sorry if I've got that wrong. I should go and check that. But you can see there's lots of turbulence that's coming in here during diastole. I think that there's the little marker there. So it's during diastole, and we've got horrible turbulence coming in, and the quantification is there with the 7 millimeters. And I think particularly if someone's in atrial fibrillation, that the accuracy of that measurement can go down. Again, with that, you've got to make sure your focus position is in the right spot. You're zoomed in on where you want to look at, so you get the best temporal and axial resolution. And particularly, obviously, that's important when you're trying to measure something that's only millimeters in size, of course. All right.
And the 7 millimeter cutoff, is that like a cutoff for yes or no mitral stenosis, or is it for severe?
No, that's for severe. And seeing as I've mentioned it, do you want me to double check that it's actually the right bloody number? Hang on a sec. I will.
That's the correct number for MR, but not for mitral stenosis.
Tell me what it is for mitral stenosis, Vishal. I'm sorry if I've got that wrong.
I think, my understanding is there's no role of Vena Contractor in mitral stenosis. And by doing this, we are measuring the PISA, which would help you in measuring the valve area.
Yeah. Just 1 second. I'm sorry to keep everyone waiting. I will get back to you on that one then, okay? Yeah, they talk about PISA, by the way, in this, and I found that I think PISA, talking to my cardiology colleagues, that PISA is not something that they'd use for stenotic lesions. It's mainly just for regurgitant lesions. They do talk about it in the literature, but it's not something that they recommend, particularly because of the abnormal shape of the orifice. All right, thanks very much, Vishal. Yeah, take out the Vena Contractor. Excuse me. This is where I got it from. Sorry, I forgot about this slide. So they have talked about the application of the Vena Contractor method for the calculation of mitral valve area and mitral stenosis. You've got about 3 patients that this has been validated on, so maybe not that accurate. And I'm sorry, I've forgotten the exact cutoff in this one. But get an idea that I guess the bigger the Vena Contractor, the worse the smaller the mitral valve area might be. All right, so let's talk about the Doppler, which is where the money is, and obviously where some of the difficulty lies with this. So the big cutoffs we've got are with 5 and 10 are the big things that I remember. It's the first thing I look at is the mean transvalvular gradient. You've got to make sure your Doppler angle is correct, and you've got to try to optimize your Doppler picture so that what you're interested in is filling the screen. Okay, reduce your gain so that you're just measuring the modal velocity, and less than 5 millimeters mild, greater than 10 millimeters is severe. It is, of course, hemodynamic. It is a sort of preload dependent, and if you've got someone who's hyperdynamic, you can expect higher numbers. All right. You're going to want to look at your left atrial size, and with that left atrial pressure, I find pulmonary venous flow pattern really useful. And of course, if you've got severe mitral stenosis, you'd expect the S wave to be much smaller than the D wave in your pulmonary veins. Pulmonary hypertension, they talk about this magic number of 60 millimeters of mercury. It can be much higher than that. And again, this would be preload or hemodynamic dependent. But of course, you'd expect pretty good going pulmonary hypertension if you've got severe mitral stenosis. Pressure half time will come on. So that's with continuous wave Doppler, looking at that sort of EF slope, if you want to call it that. And we look at the pressure half time. And a magic equation is you're just dividing it by 220. And it gives you an idea of the valve area. We'll talk about the inaccuracies of that in a second. And as we spoke about, greater than 2 is when you start to, about 2, you start to get symptoms. Valve area less than 1, that's when you're starting to hit that severe category. All right.
Sorry, Sam, one question.
Sure.
Regarding pulmonary hypertension, because I think AAC guidelines have mentioned more than 50. So
I think
Yeah,
I stole it
that's
from
right.
Anderson's book, so we'll bring it up with Benita.
Sure.
I think maybe we'll just say significant, because I still think, particularly in the critically ill, you know, having these cutoffs, like the 10 millimeters or the 50 or the 60, I think very hemodynamically, you know, can get into problems. Obviously, if someone's got a bad RV, you can have pulmonary hypertension, there would be less. If you've got someone who's got a hyperdynamic RV, those pressures might be actually overestimated. Do you see what I mean?
Yeah.
So I think if we say significant pulmonary hypertension is what we'd see, and I think 50 or 60 is not an unreasonable cutoff for those, right? But we talk about the inadequacies of the pressure half time, but this is where I think it's important having at least an idea about when you can start trying to measure areas, and sometimes that's really tricky in the critically ill, of course. Okay, so the mean gradient is not not reliable marker of severity because it's heart rate and cardiac output dependent. Therefore, absolutely, we've got to go and try and quantify it with other methods. So this is the pressure half time. You take 220 divided by your pressure half time, and you can get an idea of what the valve area is. Lewis, so this has been validated in multiple patients before based on cath. Why do we not use it a lot in, what are the problems with it, and why are we not using it all the time in the critically ill?
Because again, it depends on the cardiac output. So if it's really turbulent, then the pressure is proportional to the square of the velocity. So if you're looking at the decay of a squared velocity, you start getting into very confusing kind of log decays, and so it becomes very difficult, as on that picture there, to find exactly where the pressure half time lies. I mean, that might even be, they've taken it from the peak of the E to the base of the F, really. Yep. But would you put the line maybe a little bit flatter?
Yeah, nice. And it's the best place that they suggest is like where you get the deceleration slope. The best place you're meant to do it is using sort of that mid-diastolic slope. So you're absolutely right. I mean, I guess, do you know what I mean? I think we've got one slope that's there and then one slope that's there. Can I persuade you of that? It might not be the best example. It's that slope that we should be using. So was your argument saying I should make it steeper or I should make it flatter?
Make it more severe, flatter.
Yeah, I completely, sorry, I misunderstood. Yeah, absolutely right. So I think if you do have a sharp one there and a flat one there, you go the mid-diastolic slope. So nice. So first of all, I guess in the critically ill, it can be hard because maybe the imaging can be a bit tougher. What else? What are the other things that we have that might make it dodgy?
If you suddenly convert from sinus to atrial fibrillation.
Yeah, good man. Yeah.
Firstly, the measurement changes because you've got all of your flow coming in through that passive filling, and it immediately looks more severe despite being the same valve.
Yeah.
When you have the same, and secondly, it becomes very variable. So you get different pressure half-time readings when you're in atrial fibrillation.
And I think you can average it out, which I think probably what you're meant to do. And I guess I was trying to do it here, and they say 3 for sinus rhythm, 5 for atrial fibrillation. So you said everything right in there, and I think you've got to talk about optimal Doppler angle. You've got to talk about optimization of your picture. You've got to talk about all the usual baseline in the right place, what you're interested in, filling the screen, etc., etc. But also, I think in the critically, like, can I suggest that I think even though this is meant to be relatively independent of cardiac output and heart rate, I think in rhythm, as you said, makes a big difference. But also the left atrial and LV compliance, which if you've got something like septic shock, I think we've got quite a lot of data to suggest that your left atrial pressure can be affected as well as your LV compliance. So, yeah, I don't know how accurate it is in the critically ill. I still measure it, and I think maybe just take it with a pinch of salt. You can't do it with patients who've got prosthetic heart valves, and you can't do it post valvuloplasty either. Those are the big things, and they love asking that in the critically ill as well. Okay, continuity equation. So similar to doing it with the aortic valve, which I think we all know, you can also do it with the mitral valve area, and it's providing this idea of that effective orifice area. So maybe this is what you were getting at, Danielle, which the effective orifice area, like that Vena Contractor that we don't use really, that's a little bit smaller than the planimetry area. So especially if you're talking about if you're assessing a mitral valve prosthesis, or I think you're doing it in the critically ill, this one's an important one to look at. So again, it's the LVOT, VTI, LVOT diameter divided by the VTI of the mitral valve gives you the mitral valve area. When is this not great? Who should we ask? The other Lewis, Fiji Lewis. Oh no, now you're rural Victoria Lewis.
So this has the same issues with transmitral flow.
Yeah.
And given the multiple measurements required, any error is going to be magnified. So say the VTI measurements inaccurate, say that the LVOT measurements inaccurate, or the VTI of the mitral valve is inaccurate.
Yeah.
The loading conditions are important, and I think that we didn't mention the presence of aortic regurgitation as well.
Beautiful. And
affecting
AR. Remember what does so when you get
AF, AR,
and mitral regurg, you can get a lot of mitral regurg as well, which can really
and mitral, yeah.
And I guess mess up some of the mean pressure gradients as well. It can overestimate some of those mean pressure gradients. Awesome, thanks. And I should say, I guess in the ASE guidelines, I think they actually say that they don't recommend doing this routinely unless you've got prosthetic valves. They don't mention the critically ill in there, but I think I sort of put the critically ill in the same banner as this prosthetic mitral valve thing because it's, because of the hemodynamic status, this is the best way of trying to analyze that. Okay, so why don't we all have a go at this? Let's try and estimate what the mitral valve area is of this following patient. So I'll give you all the details in.
Sorry, Sam, one question about continuity equation.
Yeah.
So in terms of LVOT VTI, because I was getting confused when I was reading it, because I think few places have mentioned VTI of LVOT and few places have mentioned VTI of aortic valve.
Oh, I think you got to. I think you got to do. I've got it as the LVOT of the VTI. Of the LVOT VTI is what you've got to do. And I'll double check in my book. I don't know if you guys use this book, by the way. This is one of my favorite books. This is the Echocardiography's Pocket Reference book. It's really great. It's done by a sort of lead sonographer over in the States. I think he's at the Cleveland Clinic. Arizona, in Phoenix, at the Arizona Heart Foundation. It's a really great book if you're looking for it. And I thought this guy was saying LVOT VTI. Let me double check for you. So I was sort of.
I think AIC guidelines have mentioned aortic VTI.
Okay. No, LVOT here. I think either's fair game. I think either's got, as long as you're doing it correctly, I think they're both fine. If you're going to use the aortic valve VTI, you've got to make damn sure you don't have a lot of concomitant disease, I guess. the LVOT VTI might be better as long as you don't have aortic regurg or severe mitral regurg, or at least moderate. But let's try with this one. I've done it with the LVOT here, and we'll talk through it a little bit. So we've got an LVOT VTI of 2. Got the hockey stick appearance, big left atrium, thickened valve leaflet tips, thickened chordae. Yep. I've got a pretty dodgy trace here for a mean gradient here. So I've got a mean gradient of 17. I got a, oh, don't look at that. Oh, you can't look at that. And a VTI of 63. And we'll see if I've got the right number on that. That's kind of a giveaway, isn't it? I've got my flame jet, lots of variance coming through here in diastole, big left atrium, relatively normal functioning LV. Maybe a little bit of a bounce there during systole of the interventricular septum because of earlier contraction and underfilled LV, earlier contraction of the RV and underfilled LV. And then here I've got my LVOT VTI that's again a little dodgy. It's a little dodgy because I think I can see an opening click as well as trying to get a closing click. And that suggests that maybe my pulse wave Doppler is a little bit too far into the valve there. So we can bag out my imaging there a bit. But he's in sinus rhythm. And we got a VTI of, call it 16 on average. I've got my pulse wave Doppler of the pulmonary veins, S wave during systole. So systole, the beginning of the QRS to the end of the T wave. So blunting of that systolic wave. And there's a big old D wave in diastole, suggesting raised left atrial pressure. So that kind of fits the idea that we've got some significant mitral stenosis in there. And again, a holistic approach. We don't just look at the left side because if you've got raised left atrial pressure, we've got to worry about the right side of pressure that comes through because of the connection. And so that means here I've got my peak systolic RV to RA gradient, which I'm going to add to the IVC obviously, and that's sitting around about the 60 mark. And it's interesting that with respiration, am I losing the picture? Have we actually got a cutoff sign there, severe TR? Looks pretty bad on that, doesn't it? And here we've got a peak TR gradient of 62. So again, all pointing towards it being severe. So if my equation came through and said that, you know, it was only like a 1.9 centimeter squared valve, would I buy that? Because I've got pretty significant TR and raised left atrial pressure. You know, that idea of I describe as seeing the whole heart. Cool. So what is the mitral valve area of mitral stenosis in the following patient? So who's got what? I haven't done the calculations on the slide yet. What's the answer?
Yeah, 0.8 is what you get.
Is that because I gave it on the other one?
0.79 to be more precise, if you calculate it.
So tell me how you did it again, Ramsey.
Yeah, so it's again using the continuity equation. So mitral valve area will be LVOT VTI into LVOT surface area. Surface area. Not surface area. Cross-sectional area.
Yeah.
LVOT area divided by the mitral valve VTI.
Sweet. So you can either do pi r squared and take the diameter of 2 and make it 1 and do it that way. I prefer doing 0.785 and timesing it by a square of the diameter. Times that by 16 divided by 63. So that's the cross-sectional area times the VTI divided by the mitral valve VTI, and you get 0.8 centimeters squared. Excellent. Any questions about that? They'll love that in the ASC exams as well, and you will have to do those kind of. You can't take a calculator in. I don't think you can even take a pen in. I think they give you everything. It's like going through a massive security checkpoint system. But they would expect you to. This to be a kind of question that they would give you in the exam. Maybe not with weird values. It's values that you should be able to figure out on your own.
And is the calculator allowed in the exam?
No, absolutely not. No, the ASC exam is like walking into an airport. You aren't allowed to have any.
I'm talking about DDU.
Oh, DDU. You know what? We have had this actually. I did put something similar into some exams where you are given a piece of paper and you're asked to make calculation. I think it's fair game. I reckon you should be able to do the continuity equation under a degree of stress with an examiner breathing down your neck and be able to knock it out. So
Yeah.
I think, yeah, in the DDU, it's also expected. Yeah.
Sure.
I think that's fair game. I don't think we'll ask you to, I don't know, do a PISA calculation or anything. That probably is a bit much. But I think continuity equations on the fly, at least be able to, if you can't do the maths in your head, if you can't do the maths in your head, that's probably okay. But you should be able to knock out the equation if someone asks you, obviously. And I think this is my last slide. So, okay, let's just run over a few things. So the 2D, we got those 2D findings of the thickened aortic valve and hockey stick appearance. It's decordae as well. It's big left atrium. It's sec. It's a dilated RV, which may be functioning badly. We can also use it for planimetry. And planimetry is a bit shocking, particularly with transthoracic echo, because you don't know exactly where you're cutting that leaflet tip, and you don't know you've got to be exactly perpendicular at the right spot. You've got to have good gain, zoom in on the picture, have the focus position in the right spot, and stop it in the right portion of the cardiac cycle. And then you've got to try and ignore all the sort of calcification or the thicken and try and measure as accurately as you can. So obviously, I think it's probably a guide if best with transthoracic, a little bit better with transesophageal. What we do then, look at color Doppler. Vena contractors, I think, sounds a little bit research-based. PISA's not recommended really for the stenotic region. So we can use just more of a subjective assessment for mitral valve stenosis, but also importantly to check, make sure we don't have any horrible AR or MR which can bugger up the continuity equation. So the continuity equation we can use if there's no AR or MR. And most importantly, I think putting it into clinical context. So if you've got someone who's really short of breath, who's got a history of rheumatic fever, and you've got to go and assess your left atrial pressure, you've got to have a high index of suspicion for mitral stenosis. And here are the pitfalls. So with pressure half time, if you've got significant AR, decreased LV compliance, or a sudden change in left atrial compliance, such as exercise or sepsis or something, that can cause a decrease in your pressure half time, and that can, decrease in your pressure half time, which will mean you will increase your mitral valve area and so underestimate severity. If you've got a decreased rate of LV relaxation, so poor compliance, if you're after a mitral valve, a valvuloplasty, pressure half time's all out of the shop and you can decrease your mitral valve area. And then sudden changes in LA compliance, so being critically ill or doing exercise, that can change them as well. All right. Any questions about that before I show you a couple of cases? Cool. All right, let's try this one. This is a cracker, this one, actually. So, again, not the best pictures in the world, but this is a really important case for me. Okay, so we're a 67-year-old female. She had a right upper lobectomy for lung cancer. She was sinus tachy and hypotensive during the surgery, but she was kept intubated because they couldn't get her off the ventilator. And so we had her in the unit, and the next day we were again having difficulty getting her off the ventilator. Each time we reduced the pressure support, she could become tachypneic. She had some signs of some pulmonary edema on the chest X-ray. Some of that's a little tricky with post-operatively, but something wasn't quite right. A bit tachycardic, a bit diaphoretic, not difficult to get off the ventilator. The pictures are not amazing, but this is, I'm not going to stick them in a textbook. How are these coming out? Let me see if I can find you a better one.
The resolution's okay. The frame rate's a bit.
Sorry, Lewis. Yeah, it's a bit dodgy. Can anyone see? Maybe I'll just talk you through this one. Let me persuade you that they're thickened leaflet tips. So this lady's got no history of rheumatic fever, I should add. Let's see if I can I just try something? I'm just going to... It's about as big as I can make it. Can I persuade you that the leaflet tips are really, really thickened, but it almost looks like the whole mitral valve apparatus is a bit thickened. And where are we got to? So Harvey Bay, just what was I saying? If I was going to ask you to report this, if I gave you a better picture, what are the things you got to report on a parasternal long axis for mitral stenosis? Say you thought the leaflet tips were thickened. What's the rest of it?
Yeah. So anatomy and morphology of the valve. So
Nice.
valvular and subvalvular thickening, chordae
Yep.
thickening, acoustic for the anterior mitral leaflet at maximal opening.
Beautiful. And then work it back, see the whole heart. So what else do we have? So if you go for the mitral stenosis,
LA enlargement.
LA enlargement, yeah, and SEC. So sometimes we can't see it here. Yeah, and then the last thing.
Underfilled LV with septal bounce.
Nice. Very nice. Septal bounce, no systole. And then don't forget the last bit. So if you got left atrial hypertension.
IV abnormalities, yeah. Right side.
Fantastic. All right. So here we go. So we don't have a lot of tricuspid regurg here, but we do have on the tricuspid, on the continuous wave Doppler, maybe a poorly optimized trace that I've got here. I've got TRV maxes of like 4. So she's got around about 70 millimeters of mercury on the pulmonary hypertension. I don't have any pre-op echoes to analyze as well. So let me just keep that in the back of your minds. Terrible pictures. Terrible pictures. Maybe that one's a bit better. Anyway. So let's talk about the mean gradient. So where are we at? Vishal. So what do you think about this?
We could have traced it better. That's the first thing.
All right.
So no, I think, the outline, I was not very happy with the second trace. So so the mean gradient, so, we can see the mean gradient is 15.6 and which is, in the severe category.
Yeah.
And I'm just trying to see where my cursor is, whether it's at the right place or not. Looks okay.
Now taking that picture, having that in your mind, just let's look back at this. I just don't know how well it comes out. I wish I could slow it down a bit, but I don't know how it comes out. Can you still see there's quite a large orifice?
Yeah, the opening is decent opening.
Yeah, it's decent, right? There's the images that I showed you before of that guy with severe mitral stenosis. The valve leaflet tips were quite close together. I mean, this one's sort of opening up quite a long way, and I think I had a big old blazing row with a cardiologist about this case because their argument was, well, you've got a huge orifice opening. So
yeah, I think I agree, because the problem is that this patient is very tachycardic, and we are overestimating mean gradient, because mean gradient is supposed to be, when heart rate is between 60 to 80 with a sinus rhythm.
Very nice.
So I think
here we've got this that supports your argument that we've got a mitral valve area. If I do it by pressure half time, I've got it here measure 2.6 centimeters. What do you think about this measurement? Based on what Lewis said before.
That where you've measured the pressure half time there is actually consistent with where the outline has been measured for the pressure gradient. So therefore, I would say those measurements are consistent with each other, but one suggests severe and the other one doesn't, and the reason is probably loading conditions and flow.
Very nice. Very nice.
But, I think the other things we need to think about, what are the confounding factors. So in terms of LA compliance and the diastolic functions, because it's a critically ill patient, so those factors can affect pressure half time here.
Very nice. So I mean, I think it's reasonable to make this measurement. I'm going to take it with a massive pinch of salt. I think it probably a 2.6 might back up what we were seeing there with the 2D picture on the parasternal long axis. Yeah. But it sure as hell doesn't back up with why it's difficult to get this patient off the ventilator. So the clinical status, really important, and also the degree of pulmonary hypertension. But the girl has just had a lobectomy, so. Was it lobectomy, or it's a part of a VATS procedure, and so maybe that's contributing to it, but it's still significant, right? The pulmonary hypertension. So again, it's hard, right? One of the, I tried to measure a little bit better here. I'm trying to optimize a little bit better, and I've got mean gradients of say 13 that are sticking in there. You can see that we've got enormous E waves when I measure it with pulse wave Doppler suggesting, again, there's a lot of increase. There's a high flow coming through that. There's something that is blocking this off a little bit. This is probably not the best measurement. I think if you're doing any kind of diastology assessment, it's really hard with someone who's got any form of mitral valve pathology. I'd argue that the E prime is not validated in this population. So I think these images probably shouldn't even be there. We can start estimating the valve area by doing continuity. Again, not the best images in the whole world, but this is where I can start trying to measure the valve area by, doing the mitral valve area equals the cross-sectional area times by the VTI divided by the mitral valve VTI. And this again kind of backs up what the cardiologist was saying, said that you've got this huge valve opening that's going on in there. Now, I thought my argument against the cardiologist was that clinically there's something going on. This patient's clearly got raised left atrial pressure. You can see that left atrium being bowed over to the left. And I get his argument saying that you can't have significant mitral valve stenosis when you've got a valve opening that's that big. He also thought the fact she wasn't in atrial fibrillation was suggestive that we're probably not dealing with stenosis. And I totally buy that. But I want to talk about the idea of what's known as functional mitral stenosis. So this is something that's talked about in J.O.'s book, the guy from the Mayo Clinic in the States. And he talks about functional mitral stenosis for people who's got relatively minor mitral valve stenotic disease. So from something like degenerative changes on her, from like an elderly lady who's got degenerative changes on both her aortic valve and the mitral valve. I don't know if I could show that to you again. But just you see her aortic valve was not normal. I measured up the LVOT VTI and I measured and I don't think that aortic valve up at the top looks normal either, which kind of points to this idea that she's maybe got this degenerative change. It's that whole valve that's being affected. It's not a rheumatic fever. I think it's this degenerative changes in her heart. But when we went back and spoke to this lady, she was short of breath when she was doing a lot of exercise. When she was mobilizing, going for walks and stuff, she'd get quite short of breath. That was put down to the lung cancer, but maybe it's because she had some relatively mild mitral valve stenosis. But when you exercise and you increase and you're making a tachycardic, she's at 120 beats a minute here at the moment. When you're tachycardic, you get what's known as functional mitral stenosis. And functional mitral stenosis is classically something that's described in the assessment of mild mitral valve stenosis with patients undergoing exercise stress tests, and which is what this guy J.O. does a lot of. And they suggest that if you have someone, when you make them hyperdynamic, if you get the mean pressures above 15 is the kind of cutoff where you start saying that is functional mitral valve stenosis, as in it's relatively minor disease and it only comes on when you're exercising, but it's significant when you exercise. So in these circumstances, greater than 15 millimeters of mercury is what he suggests is important when you're doing exercising patients. Along with that, you also see significant pulmonary hypertension. And I don't have the repeat imaging, but when we repeated the imaging, her gradient, when she wasn't tachycardic, her gradients went right down, her pulmonary hypertension went right down, and everything kind of looked like it disappeared. So that's why it's important to rate control and repeat the imaging. So quite an interesting case from the critically ill, I thought. Any questions on that?
No, we get that quite commonly here.
Oh, of course you do. You're in Darwin, but you get rheumatic fever. Tell me about this. You see this all the time.
Yeah, all the time. And it's I think it's a real thing that stops people getting off ventilators, and you can get into all these arguments about definitions and boundaries, but then if you treat them as if they've got severe mitral stenosis and try them out even further than they are, then and then you've got some scope to rate control them. So it happens because there's a lot of bronchiectasis here as well. So you get people who go into florid pulmonary edema without very significant mitral stenosis, and it's just a combination.
Wow. And do you see mean gradients of above 15?
Oh, the biggest I've measured would probably be in the 30s.
Solid.
In sinus.
Okay, amazing. Oh, excellent.
Yeah,
So,
I've seen a few cases as well. where the echoes at the time of the development of pulmonary edema and pulmonary hypertension have looked like severe mitral stenosis. It's then been re-echoed later in the clinic, and they've had mild disease. Particularly a patient we had with anaphylaxis on an adrenaline infusion went very tachycardic, high systemic blood pressures, and was very difficult to get off the ventilator. Good case.
Well, I mean, so I think it's a real deal, and I think maybe these kind of cases highlight why we need to be learning to do advanced echo. Again, I'm not suggesting that that we should all be, I don't know, reporting, and I'm suggesting, of course, the cardiologists have a slightly different bent on things because of their outpatient work. But I think for the critically ill, this is a real entity, and I struggled to persuade the cardiologist that this was affecting this patient's care. And I think it's an example of why I think we need to know how to do echo, because there's no doubt in my mind that this was stopping her getting off the ventilator. In terms of rate control with these guys, what do you guys use for your patients? And drying out, so diuresis, what kind of rate control do you use? Is it just metoprolol?
Yeah. I mean, usually
that was all we had available.
Okay, sure. All right. I did have one more case, but I think we're sort of out of time there.
So that patient which you just presented, was there significant MR that contributed to the LA enlargement and back pressure?
Yeah, very nice. And it's exactly like we were saying, you've got to go checking for the MR. I don't think I could see a lot of MR on the color Doppler on that patient, but you've got to go looking for it, because of course, if you've got a whole bunch of blood coming back, you can have, you've got the problems of then increasing the gradients by when it all comes forward again. Yeah, I didn't think there was a lot of MR in that case, though. All right, guys, we should probably call it there. Unless there are any other comments, I'll say thanks very much and see you guys next week.
Thanks, man.
Thanks, Simon.
Thanks.